we're doing so many new things that are not having been educated when I went to dental schools. And the most important thing for me that Ziv will have to keep me screaming and kicking out of the office, that I want to be there because I am very fortunate, and I can only give everybody the advice. If you can get yourself a good associate, if you can have partners, and if you can be as fortunate I have been to have somebody like Ziv for over 25 years, and then have the addition of Lloyd and Dr. Alex, there is not a day anymore that I don't give any more pearls. I receive pearls every day, plus a laugh, a little bit of meditation by Lloyd. So it's really fun to practice. I want to review something that every periodontist is able to do, and every one of you knows the problem of periodontal patients having recession. This is our bread and butter stuff. Like you do simple restoration, we are used to treat recession, and we are confronted every day with patients who have extensive recession. And the main reason why you are concerned about it is that some patients don't care about it, but we know that eventually they cause sensitivity, caries, and the most important thing is they contribute to bone loss, and an extensive recession makes the tooth also less stable. So our bread and butter stuff was to treat those areas with gingival grafts, and we know they worked very well in the beginning, just simple with free gingival grafts, but we perfected the technique of taking tissue from the roof of the mouth, the palate, and since we have perfected the technique of doing donor tissue, palatal tissue, we still, and you have the trouble to convince the patient to have this procedure because everybody dreads the pizza burn, the roof of the mouth. But now with the technique of doing gentler surgery and having PRF, they survive it, but people are dreading it. The problem becomes when a patient like this presents to you with an area on the upper right, upper front, upper right, upper left, lower front, and now you're thinking like, how am I going to get this patient back maybe 2-3 years later if we are starting to do gingival grafts on the upper right, upper left, the lower right, and we are waiting for the palatal donor sites to heal, and it takes 6 months, and then we have to go back. And this presents a challenge, and I used to joke that this is like the 5-year Russian plan until the patient gets back to you. And unfortunately, a lot of patients quit after the second surgery because it is painful, it's time-consuming. So what is the answer for something like this where nearly a full arch needs to be treated? Basically, I was lucky to be exposed because it has, and unfortunately is not being taught very much in dental school, to be introduced by somebody who invented a new technique. It's the tunneling technique. What is tunneling? Tunneling basically means that we are creating a tissue tunnel, and we are creating a bed to receive tissue. And now, instead of only being able to take tissue from the roof of the mouth for 2 teeth or most 3 teeth, we can combine the technique of knowing that donor tissue behaves very similar to the connective tissue that we are removing from the palate. It totally falls apart, totally regenerates into dense connective tissue. And that's one thing that we are trying to educate the patient. Do I live with somebody else's tissue? What do I expect? There is 0 rejection rate. It's normal healing. It just takes a little bit longer. And the only challenge is to create this tunnel without separating the papilla, and that's the cardinal rule. As soon as we break 1 or 2 papillas, we're in trouble because then we have a very compromised healing. And then we are, after the tunnel is being created, we are squeezing this donor tissue in that takes a little learning curve, and I call it like the reverse birth, and basically soak the area, the donor tissue in PRF, and there is a very particular technique to suture, which takes, during this procedure, actually the longest time. And after this procedure, if you happen to see the patient, it's not a pretty look, because we are bunching up the tissue and we are apically repositioning it, and the papillas look bunched up. And the only, I don't want to call it side effect, but the only thing is that those sutures need to stay much longer than was conventional grafting, because the only challenge with this technique is that instead of your own donor palatal tissue that literally falls apart and regenerates in 2-3 weeks, this donor tissue takes about 4 to 6 weeks to totally disappear. And there are scientific studies to show that they basically create your own dense connective tissue. And that's why after a certain amount of time, we can get with one procedure, one surgical procedure, you can see the upper right, the front area, upper left area, as well as the lower front area being treated, with the big advantage that we have only one surgical procedure, one post-op event with very little discomfort. Unfortunately, it's less discomfort, but more swelling and kind of bruising that's very easily being handled. And we can deliver this patient in much better health back to you to either be continuing with restorative treatment or get back to your recall. And especially with surgery patients, we are always confronted with discomfort, that they don't know that we are removing a challenging distal pocket on tooth number 17 or 18, but this is very rewarding because they can immediately see this effect. So you can see here that, again, if we would treat this with a conventional donor tissue, we would have to go to the palate, at least to the upper right and upper left area, because we can't handle more than 2-3 teeth. And you can see this, that after the grafting, it is so much easier to provide a nicer result for the restorative dentist, and much better harmony. It's easier to clean, and again, done in one procedure instead of multiple procedures. It's a very rewarding procedure, especially in the aesthetic zone. And the only challenging part is that when we look at the next cases, when we are confronted with certain defects in the teeth, you can see here that we can get some class 5 erosions that we can cover, and you will see when it gets more extensive, we can get some very, very nice results. And when we continue, you will see that in some areas, it looks like if there was never any recession present. So my case, when a patient like this is referred to us by one of you guys, well, it doesn't bother me. You know, I'm not planning to be veneers, and maybe they don't even have a high smile line. But most of the time they're already educated, and if not, what I try to explain to the patients that it's not only about the aesthetic, it's not only about the sensitivity, but when we get a case like this back, we are preserving the periodontium and preventing further bone loss. And I try to explain to the patient that when you have this kind of recession, in the normal circumstances, the bone is like 2-3 millimeters underneath there. If this recession continues, those teeth eventually, besides being sensitive, besides being more caries prone and maybe being bothered by aesthetics, you will lose bone. So this is not only an aesthetic procedure, but really preserving the periodontium. So here we see a few other cases where the class 5 restoration may have been necessary, but here we are covering the area and restoring the periodontium without any kind of restorative treatment. This is very challenging for a non-surgeon to understand, because if the recession in the area of tooth number 8 would have been treated conventionally without a tunneling procedure, we would have to raise a flap. And invariable, we would compromise this papilla and actually cause some black triangle. By doing the papilla preserving technique and doing a tunneling where the papilla is not being detached, we not only get very good blood supply, but we get this beautiful aesthetic result. And we can see even with the donor tissue that we get this stippling that is so typical of when tissue is being taken from the palate. So here are just a few examples like pre-restorative, where we preserved the periodontium, got some root coverage, and then the patient was not happy about color and shape or whatever, and had some restoration after the procedure. With the big advantage that we got the case back not 2 years later, but a few months later, back to your practice. Here's another challenging case that without the tunneling technique, the papilla would have been compromised, and we restored it back to health without any kind of other problems. Please try to refer us the easy cases. Lower teeth are so challenging. The root proximity, the buccal loss of the bone, the tissue is so thin, but having done this procedure for all of us and developing a certain technique, just imagine that we are going with the instrument here underneath there. We'll have to tunnel this without any perforation, because once you perforate, once you detach any papilla, it's time out, and we explain to the patient, it's either we abort the surgery or we go back to taking tissue from the roof of the mouth and doing the conventional. So those cases sometimes are very challenging, but they work. And here's another case to show you that when you get those cases treated back from us, sometimes when there is only very thin mucosa covering the tissue and we advance everything, you will see a very light shine of the mucosa still covering it, because we are not changing the outside. But you will see that even if this very thin tissue moves a little bit, underneath there is very dense connective tissue protecting for further recession. Here you see a very challenging case where treatment was done. In this case, we discussed this with the dentist, should we pre-operatively put some class 5 restoration or not. The patient said, I don't care, I just want to be healthier and not lose further tissue. So after the healing, you can see that we got some tremendous root coverage. And in this particular case, I referred the patient back to do a much smaller class 5 restoration, and the patient decided, I want to just have it smoothed off. I don't care about the aesthetic, but at least I have some firm tissue preventing any further recession and further bone loss. In another case where we know that treatment needs to be necessary, but we can't put tissue over old class 5 restoration, I don't want to go to the boring technique of how doing it or whatever, but we basically are taking a lot of time to prepare the roots. In this particular case, we were aware that the class 5 restoration were very shallow, so I removed them, treated the roots, and I think got a very reasonable result without having to go back and redoing some class veneers. Lastly, but not least, that's one of the fun things why I still love practicing. Most of our cases are being treated and being referred to you, and we are lucky if we see a 1 or 2 year post-op. This is one of my first cases done 15 years ago. How would you treat this case in a conventional way of doing individual grafting from the roof of the mouth with donor tissue? It's a 2, 3, 4 year project. We basically convinced the patient. I didn't tell her that she was my second or third case, but she somehow trusted me. And we basically created a tunnel on the whole maxilla. So you can see here the tunnel being created. Now you can envision the amount of available tissue by having the donor tissue being available. We can use as much as we want. So we basically have enough tissue from the molar to the central, and from the central going back to the other side of the molar, and insert this tissue into the tunnel, soaked in PRF and growth factors. and then you will see the case being sutured. So here you see, and this is sometimes challenging, and sometimes this takes some time, but it's kind of fun. So here you see the donor tissue being inserted, the suturing technique, and 5, 6, I like even 7 weeks if I convince the patient to keep those sutures, and basically only topical anesthetic, 10-15-minute appointment with a light polish. You can see how the result is once we remove the sutures. Now, the beautiful thing about this particular case is that the patient was very motivated to get restorative treatment and some minor orthodontics, and basically this patient was abroad and came back to us a couple of months ago, and this is a 15-year result, which really makes fun when you have a patient walking in 15 years later and actually smiling and thanking you for a surgical procedure. It makes all our hard work worth it. And this is actually the end of the lecture, and I want you to understand that we actually, with all the hard work, have fun in the office because we get to do work that we love, and we treat your patient, and we appreciate to have that honor. Thank you very much for being here tonight.